Okay, and the first speaker is Professor Lampros Michalis. It is probably the key lecture for this year meeting, because actually he must to summarize maybe the main topic of last 30 years, because the drug-eluting stents are, 20 years. Lampros.
Thanks a lot. Thanks a lot, Dobrin. Thanks a lot, Valerie. It's a real pleasure for me being here to talk about the impact of death in interventional cardiology. So to summarize what we've been listening the last 2 days or something like that. And it seems to me that the whole thing is getting a bit emotional. Possibly they asked me to do this lecture because I'm the older here, with the exceptions of Eve, who is older, but I'm almost the older. So we need, in order to know the impact, we have to know where we've been studying and how these things starting and ending up. So need a bit of history. And because I see many young people who think that Earth and Internet have been created the same day, these two things have been created the same day. So we learned how to do, we learned how to do a safe puncture in 1953. Till then, the only way we didn't know how to do a puncture, and only we have to do surgical cut downs. And in 1958, just by accident, we opened a sacred door, the door of coronary circulation. Till then, coronary circulation was something sacred, and nobody should be able to touch it, and Mason did a coronary angiography by mistake. And to go a bit further, in 1977, Andreas Grunzig, whom I suspect we should offer about a certain percentage of our income every day, because if it wasn't for him, we wouldn't have been here, and possibly cardiology wouldn't have been here, invented or found the balloon angioplasty. It took us 10 years to move from POBA and all different devices, because in the meantime we have invented many devices. Some of them, they are still around, like rotablational atherectomy, and we moved to stents. And it took us another 10 years to go from just the metal stents, the stainless steel stents, to the drug-eluting stents. So you can see here the history all these years, and you can see that we have a change every 10 years, something like that, every 10 years. And then every 10 years we try to improve exactly the stents that we started using because apparently we had problems. And start with this stent, PTCA, why stents? It's this question is a bit biblical, like what Apostle John says, in the beginning was the Word, and that's how it starts, it was the Word. So in the beginning was POBA. And then we went to stents. Why is that? Because I remember the days when I was doing POBA, that every 10th patient I have to rush in the cath lab in the middle of the night. And why was that? Because the vessel was occluded due to traumatic dissections. That was the main problem. We had also other problems. That was the stenosis, which it took us a few years to understand that we had two different mechanisms. One was the recoil, and the other was the intimal proliferation. So the stents, if you ask me, the reason why it's been invented is to stop this rushing in the middle of the night into the cath lab. But as soon as we started implanting stents, we found a few different things. First of all, that it was very difficult to put the stent in the side of the pompa. So we have problems with to deliver the stents. Also, the other thing is that quite a few patients that they had the stent, still they had stent thrombosis. And the majority of the stent thrombosis in the beginning was acute. And then less than with POBA, but still quite significant proportion. And then also we faced with subacute thrombosis, a bit later thrombosis. And after a while, we've realized that although stenosis was much lower compared to with POBA, still was there. And I have to tell you that the expansion, the big expansion of stents was due to restenosis. Of these papers which showed that we had less restenosis with stents than we had previous one. So we had to sort out the problem. The main problem that we thought that we have to sort out in 2000, around 2000, was the in-stent restenosis. So we invented the DES. And the reason for that was to sort out the in-stent restenosis. So after using the DES, we found that we still have a bit of restenosis. It wasn't 0% as we anticipated with the first studies, but it was less. But we had other problems. What were the other problems? The other problems was the stent thrombosis. At some point, we thought that it was much worse compared with the BMS, and that created a lot of problems if we have to use them or not. And in any case, we decided that we need a long duration of dual antiplatelet therapy. Till then, the dual antiplatelet therapy was for 1 month, 1 month aspirin, 1 month ticlopid in the beginning, clopidogrel afterwards, and then we moved to 12 months of dual antiplatelet therapy with all the problems that dual antiplatelet therapy creates. And then we started thinking, why was that? Why we had these problems? The problem mainly with the stent thrombosis. And the hypothesis that we made was that when you put a bare metal stent, you traumatize the vessel and you get a lot of healing effect, like the scar, a big scar, like the one that you had after an operation. And that healing effect causes restenosis, but stops thrombosis. But when you put a drug-eluting stent, you stop this bad healing, so you have a delayed or possibly not healing effect, and also inflammation, and that you have the stent thrombosis, which adds up to death or acute myocardial infarction. And then we thought that we have to sort out this problem. And what we've done 2 things. That's the 2 things that we could play with. One was the platform. The platform was the stent, which has the metallic stent and also the polymer. So we changed the platform. We tried to make it thinner. We changed the polymer. We tried to make polymers that were more less inflammation, more biologically compatible with the vessel. And the other thing that we could play was the drugs. So we stopped all Taxus and we said only Limus. Now we will use only Limus. So we stopped Limus. And that's how we created the second generation of DES. Which, and then what has been, we left with the thrombosis less, a bit not very good deliverability, and that's why we decided that we need a few further changes, especially on the design of the stent, making thinner, deciding how you will put the crowns, how you will connect, how you will make the links, and possibly make a biodegradable polymer or also possibly no polymer. And that's how it creates the third generation stent to be very simple. You can listen to many things about that, but that's what it is. So the third generation, which we still have very little data, but has 2 different things. One is try to reduce inflammation by changing the polymer, making biodegradable or abolishing altogether the polymer, and also we try to achieve higher procedural success by improving conformability and try to deal with more complex lesions, which are calcification, bifurcation, and left main. So we changed a bit the metal alloy, we ended up with chromium cobaltium, we changed the design, and we reduced a bit the thickness. So let's go back to the problems. What are the problems with DES? One is the in-stent restenosis. The in-stent restenosis, we have the initial, you know the definition, that has to be 50% smaller. But what we always thought that restenosis is the new, you have a healing response and you have smooth mast cells and extracellular matrix, and that's what is create the neo-intima formation. And it is true, especially for bare metal stents. But when we got the DES, we thought, we noticed that it wasn't only that. Possibly it was something else. And we tried to understand it both with experimental work and also with OCT studies, and we found that it wasn't only neointimal hyperplasia, but now we have neoatherosclerosis. So we have something like evolution of the atherosclerosis through the stent. We didn't know till then that this existed altogether. It's a new thing. And you will tell me, why is this important? Well, it is important still, restenosis, although we know that it's been we have a low incidence of restenosis, this, the other. If you think that 10% of the contemporary practice, 5 to 10% is because of in-stent restenosis. So in-stent restenosis even now is a problem. And I'm showing you these few pictures to see, look how it looks there, the neointimal hyperplasia, and look how it looks there, the neoatherosclerosis. This is like old plaque, that's atherosclerotic plaque. And that's why that breaks, and that's why you have acute coronary syndromes, true acute coronary syndromes with neoatherosclerosis. You didn't have acute coronary syndromes, true, with neointimal hyperplasia. Possibly we had this gradually sort of a decreasing reduction of the lumen loss, and possibly a bit of thrombus because of the very high sort of stenosis, but not this acute coronary event. So let's go now to the stent thrombosis. That's what about atherosclerosis. The stent thrombosis. Stent thrombosis, first of all, you know what is that you have a thrombus full of clot inside the stent, and in the old days, after the DES, we understood that we can have it either 24 hours or the first year, or after the first year, which we call it very late. We didn't know about that before DES, the very late. We sort of knew something about late, but not the very late. And now you will tell me, where do we stand with that? To be honest, with the first generation DES, that was a big problem. With the new generation DES, this problem has been decreased, but is still there. It's about 1% of our patients that we treat. So you will tell me, in the end, because in the beginning, as I told you, we had a lot of problem with the first generation drug-eluting stents and the BMS, and everybody sort of was wondering, are they any better or they are still worse? What I can tell you very quickly is that for late stent thrombosis, the second generation, mainly DS, is even better than the previous stents, the BMS, the stainless steel stent. The very late stent thrombosis, they have similar results. There's a bit of this is not the truth 100%, because it was much sort of benign, the stent thrombosis with the BMS, that is now, it was less acute. We have a much more, possibly the vessel was blocked, the artery, but it was through sort of this hyperplasia, so the myocardium possibly was better prepared to get this adverse event. And now we said about neoatherosclerosis. First of all, is that something indigenous to drug-eluting stent, or something which we didn't know but it existed? And the second, does it have anything to do with the stent thrombosis? First of all, if you compare the first and the second generation, we can say that for the first and the second generation, mainly the DES it's something, the neoatherosclerosis is something which didn't in the first and the third year. That didn't exist with previous stents. Now, if you go beyond the 30 years, then even the BMS had a bit of neoatherosclerosis. But for the problem is with the DES, you get it earlier. Now, and also, if you see there, it increases over the years. You go there, goes up, does not stop. But then you will tell me, is it any bad? Well, both for stenosis and for a late stent thrombosis and the very late thrombosis, the impact is low. If you go there now, you go down to 0%. So it's not bad, but it's still there. So what we have achieved, first of all, with the drug-eluting stents, even from the first generation, what we achieved is that we needed less repeat revascularization procedures. That was the big impact. We didn't gain anything about death or ST elevation MI, but definitely we had needed less restenosis and less repeated procedure. And with the new stents, the second generation, what we managed to get is even further reduction for the revascularization procedures. And if you look at here, this is something which for the new generation of stent, it is getting lower even after the 12 months. It's not only in the first 12 months, but even after. If you get for the first, we managed to get less for the first 12 months, but then sort of was equal with the BMS. But with the DES, is even lower after the 12 months. That's the big achievement. Something that you have to bear in mind. In stent restenosis, the way that it presents with the DES is it comes late. With the beginning, when I was a young boy and we have the BMS, we said you will have a stent, if you get restenosis, it will be the first year. After that, it's okay. Nothing will happen. You can't say that with the DES. That comes later. We don't have a lot of difference in the hospital outcomes, has the similar presentation, but comes later. That's what it is. And because of that, that started changing a bit our practice. I'll give you a glimpse of that. I'll talk to you a bit more, another slide later. So what it does, now it makes us not too afraid to put stents in the left main and the proximal lady. We didn't do that in the beginning. And indeed, because for this type of intervention, we get less risk for cardiac death, MI, and repeated vascularization. So now that helped us. That opened the door for more complex procedures. So with the third generation now, there are a few papers. They're not very big papers, and if you look at them, they are full of tables. I can't put you all these tables. So, but if you take now this thing, this third generation, it is what it is better than the second, that you can deliver better because they have thinner struts and they have better design. Possibly you can use it better for bifurcation because you have the easier access to the side branches. Possibly they have increased radial strength, and possibly it seems that now we can stop the other big problem. After we faced the problem with the first generation DES, and we started the dual antiplatelet treatment for the long term, 12 months, we never come back again. We haven't come back again. Now we started thinking, and possibly that is due to the new generation of drug-eluting stents. That's one thing. And now indeed, and if you look at this, what you get with the third generation of stents, then the MACE is similar if you give it for 3 to 6 months or for 12 months. But something else there. If you still give it for 6 months, you don't decrease the bleeding events. So if you want to have less bleeding events, you have to go back where we were with the BMS to the 1 month. And it's true. If you use it just for less than 3 months, then you have 39 reduction of bleeding events. So if you want to decrease the bleeding events, you have to be able to stop it soon. 6 months, 3 to 6 months is not enough. You have to go below the 3 months. Now, what about this strut thickness? Strut thickness, you know, everybody now is reducing the thickness. Well, what you get with this reduction of thickness, you get less target lesion failure, so less restenosis, but you don't gain anything about MI, ST, cardiac death, and all-cause mortality. So, but you get a bit less restenosis. Is there any price to pay? You don't use it in big vessels like left main because of recoil. When you think that will be recoil and you have a lot of pressure from outside, they don't work very well. So you have to be a compromise. So with all this knowledge and without tested it, we moved a bit forward. As you know, the cardiologists are brave people. They're brave souls. They do things because they feel that they can do it. And what did you do with this BMS, with the drug-eluting stents? We increased dramatically the rate of complex PCI procedures that we do. We changed our practice altogether. Now it's different practice. And what did you do? What did we change? Well, we didn't increase the CTO, although this used to be a CTO meeting. The CTO number has been decreased. Not because of drug-eluting stent, but because we don't believe very much as we used to do in CTOs. What do we do? You do many more left mains and bifurcations. That's what we do. And you can see here, and why we did that, and now we feel very encouraged The reason why we feel very encouraged is because since 2014, we see that we get less restenosis. Still, we get the same deaths, but we get less restenosis. And we are very the cardiologists, they believe what they see. We don't see very much the death, it's not very often, and we don't see the dead man, but we see restenosis. And we see less restenosis, so now we are braver, and we do all these things. Now, about restenosis. Is that important? We always knew that in-stent restenosis wasn't an easy task. Even with bare metal stents, it was difficult. But what we did, without a lot of thought, is go there, put a balloon, open it up, put a stent, finished. That's what we did. We tried at some point before the drug-eluting stents to do debulking with rotablation. The older people, the people there possibly remember these studies, which didn't show anything. Debulking. So what we did is just balloon, stent, finished. Now what we know now is this is not an easy thing. And when you see in-stent restenosis, check it. Check it with intravascular imaging. That's a difficult thing. You have to know if it is under expansion or neointimal hyperplasia or atherosclerosis. And then you have to be careful, and you can use all sorts of different sort of algorithms and try to deal with this restenosis. Restenosis is difficult. Has always been, but now it's not only one thing. Possibly you have to overexpand the stent. Possibly it wasn't good enough. And now we have tools that we can try to achieve that. So, it's not drug-eluting stents that had an impact, but the whole thing has changed over the years. Our understanding has changed, the way that we treat has changed, everything has changed. And what do we do differently compared to previous years? I'm not going to tell you about 1990 when I started doing angioplasty. We do possibly more things differently, but even more contemporary times. We do more difficult lesions, definitely. We deal with more difficult patients. Possibly the patients nowadays that they have coronary artery disease, they are not the same. They are different. And possibly the lesions are not the same. It's not because they are only able to tackle more difficult lesions. The vessels are more difficult. Don't ask me why they are more difficult. I believe that's because of statins, which are fantastic drug, but as everything which is very good has a sticky end, and possibly that increased calcification, but it's my personal sort of view. Nobody says that, but it had more difficult lesions, full of calcium. That's the big enemy now. And the patients, we keep them alive, and when they come, possibly we do less intervention to stable angina, but when they come, they're difficult patients. Elderly, comorbidities, chronic renal failure, poor ventricles, or whatever. We have a weapon, DES, and all these clever weapons, they are potentially dangerous. You have to know how to use them. It's not like a stent, crack stent, difficult. So what do we have to do? We learn now that we need to derogate the lesion. I don't know if it's going to be through intravascular imaging, coronary physiology. I started nowadays doing my derogation with CTCA. I can't tell you if it's good or bad, but I try to plan the whole intervention with the coronary, CT coronary beforehand. And I think I know much better the vessel. I don't need so much intravascular imaging. So definitely, if we know what the vessel is, we need to do plaque preparation. That's the main thing, plaque preparation. You have to have a nice plaque. As Steve said before, you have to be able to put a stent in 3 atmospheres and finish, because the plaque has to be amicable. If it's not amicable, don't put a stent. Try a drug-eluting balloon. Do whatever you want. Don't put a stent if you know that is not going to expand well. It will not behave well, and you will pay the price. And we came back in the initial days of Ticlopidine and Colombo, that we need a very nice finish. So now we went back to post-dilatation. We post-dilate now. We had stopped that. We pre-dilate and post-dilatate. The era of this we've seen an example today of direct stenting, for me, has gone for the majority of things. And we restarted using left ventricular assist devices. When I was a young boy, intra-aortic pumping balloons were very popular. I started with a sort of a mad guy then, which used to do high-risk PCIs without stent with ECMOs. But that's how I did it in 1990. That has forgotten, but now it comes back again. I'm still very much fond of intra-aortic pumping balloon, and I think that this point 3, this 3 contraindication in the guidelines is not right, but possibly this, possibly more, possibly others, but we have to deal with this. We don't know exactly which patients will be benefited. It's difficult to judge, but definitely there are some that they will benefit it. And I would like to finish with this thing. Contemporary PCI is not simply NDES implantation. Think of that.
Well, congratulations for this presentation. I'm really amazed, as always. So, questions, comments?
Very nice presentation. Thank you, Dr. Michalis. I also remember that time when we used stent buy from the surgeons. Afterwards, we used stent buy for our procedures. But my question is the follows. Are there places for bioabsorbable stents now? Because we know the situation with Absorb in the past, and we were very disappointed of those results. But now there are many stents to be tested.
My question always is, first of all, we had already bad experience with bioabsorbable stents, but fair enough. The question is, what do we want to achieve? If we're going to achieve this late neoatherosclerosis, I'm not so sure. That's a possibility. But again, I have this feeling that the reason why we had less neoatherosclerosis with bare metal stents is because we had a lot of neointimal hyperplasia. So everything was well buried underneath the ground. So you had the neointimal hyperplasia, so nothing new can come from behind. It was sort of a burned ground, the vessel wall. I'm not so sure if you have this bioabsorbed thing, how well the vessel will be healed and how much sort of a thing will have there that will keep it quiet underneath, if that's the case. If the case is to be able for the surgeon to implant a graft sometime in the future, if it finds sort of a healthy part of the vessel, that's a possibility. Although what I'm saying that when I see all these patients with long lesions and these patients, the reason why the surgeons will not put a graft is because they can't find something which will be easily graftable, not because of a stent. If you go very diffuse disease. Although I don't like to put stents for diffuse disease for other reasons. I try to treat them with balloons, drug-eluting balloons, long inflations. Remembering all my days that we have to put a sort of inflated balloon for 2, 3, 4, 5 minutes, 6 minutes to tuck the dissection or whatever, we've gone back all these years again. So it depends upon what is the reason for that. I can't find a good reason, but possibly it is, which I can't find it myself. But definitely also depends upon the industry. If industry wants to invest on that, and they do it, then it will come. Because the industry persuades us in the end and makes the decisions in the end for some reason. Not always, but most of the time.
Ravi?
I didn't have a question. I just had a remarkable observation when you show that the rates of TLR and death are all flat with whatever stents. And the remarkable fact is that the complexity of our cases have gone up so much, yet the TLR and mortality rate has not gone up. And that's, I think, all credit to the inventors, manufacturers of all those stents, and of course the operators who use it in the right way, that these products have become so safe. But we don't think twice about doing left main bifurcation, and we accept the same kind of good result.
I found your statement about the direct stenting quite provocative. I agree. I fully agree with you that that's the right approach for the bioresorbable scaffolds. You cannot implant directly the bioresorbable scaffolds, as we heard in some meetings and as we have seen in the past. But with the metallic drug-eluting stents today, I mean, we obtain pretty good results. Especially, I mean, even if you got some under expansion or so, you have intravascular lithotripsy and shockwave or so on, you can always overcome the problem. In some scenarios, for instance, in acute coronary syndromes, unless I see something which I do not feel confident about, I even prefer the direct stenting because I reduce, theoretically, the possibility of distal embolization and so on. But I'd like to see your comment.
First of all, I'm glad that you've seen that was the only statement that you thought that was provocative. That was good, actually.
Well, what's the percentage of direct stenting then? It has to be small, no?
Well,
Very simple.
as you mentioned, it depends on the complexity of the lesion. I mean, in complex lesions, I mean,
Yes.
it's not wise to go for that. But in many acute coronary syndromes,
Yeah.
if you don't see, I mean, if you can see the distal vessel, usually it's a soft plaque that you can direct stent. And I don't know, probably it's a wrong intuition, but I have the feeling that the likelihood that you get the distal embolization is slow flow or no reflow, maybe it's less by doing that. I don't know.
I'm not so sure, actually, if this direct stenting stops this embolization, this non-reflow. I'm not sure. Nobody has shown that. In any case, first of all, one of the things is that nowadays the possibility of seeing something without a sort of symbol is very small. In the old days, we had softer plaques. We don't have this type of plaques now. There's always a bit of calcium, a bit of this, a bit of the other. And what I try to emphasize here is that we need to prepare the plaque before we put the stent. Now, if you are 100% in the way that it was today, that wasn't any calcium, it was just soft plaque, fair enough. But you have to, the idea is people prepare, that they have to learn to prepare the lesion. Try hard to prepare the lesion. Don't leave something that put a stent when it's not going to expand, it's not going to be this, the other. Make sure that you will do the best out of it before you implant the stent. Otherwise, you will pay the price. And the price will be either stent thrombosis or stenosis, which then is going to be difficult to be sorted out.
Dr. Nair, rules of engagement. The first part, this is how to select this. And then Juan have to cover practically the second part of and all the tips and tricks about this. And probably I will leave you in 5 minutes.
Yeah. So let me mention some historical facts. So I work in a cath lab which is named the Soanes Cath Lab because, of course, Mason Soanes was the interventional director and the head of the department there. And for those of you who don't know how Mason Soanes did his first angiography, he was performing a left ventriculogram, and while he was injecting, because of the PSI, the catheter inadvertently fell into the aorta and then went into the right coronary artery. And there was only one X-ray technician, and they all ran to get the defibrillator because it was felt that if you inject the coronaries, the patient will fibrillate. But fortunately, even though they used ionic contrast and injected a large amount, nothing happened, and you got a nice visualization of the right coronary artery. And that is how coronary angiography was first performed. And then since then, of course, it took off. I had the privilege not of working with Dr. Soanes. He was well before my time, but I did work with other people that had worked with him, but they are now all in their late 70s, 80s, and some of them have passed away. And they all had very interesting stories to tell us about Dr. Soanes, who was also a very heavy smoker. And in those days, he smoked a cigarette, put it down there, went into the X-ray room, shot a picture, came out and took a few more puffs. The picture, a painting of Dr. Soanes we have in one of our conference room, has his hand down there with the cigarette down here. And when Eric Topol was the chairman, he told one of the painters to please paint that cigarette off. So his fingers are here, but there's no more cigarette in those fingers. And Dr. Soanes, of course, he died of COPD. So when we were training, and I was training in Cleveland, it was a matter of pride for those people that trained me to, and us, not just me alone, for them to insist that we did coronary angiography using the Soanes method. So we had to do cut downs and use a Soanes catheter to do coronary angiography, whereas everybody else was doing femoral. Some attendings insisted that we do the Soanes technique. So even today I can do a very nice cut down, and we can use any catheter that we have to get into the coronaries, because the Soanes catheter was not an easy catheter to use. We, of course, don't have it anymore. It's only in the museum. Anyway, I thought that was a very nice historical fact. Of course, there are many, many stories about him. Anyhow, my presentation is now on how do you select DES in certain specific patient population groups and in certain lesions. I cannot cover every patient population group, such as STEMI or NSTEMI. Of course, I cannot cover every kind of lesion, but I will present some more common scenarios. Now, this morning we heard from some representatives from the DES and other stent companies as to some of the characteristics and the attributes of some of the stents they make and how they have evolved over the last 30 years with different stent platforms, the material that is used to make stents, the polymer, the drugs, etc. And we've heard that many of them are used in certain situations and how each one is better than the other. I don't work for any company, so if I mention any particular stent, it's because of the data that has some evidence that certain stents are perhaps better for certain situations. And of course, my personal bias also as to when we would use a particular stent in what particular situation. So with that, how do I go forward? Advancing is okay. So I'll start off with aortoosteal disease. And the locations of aortoosteal disease can occur with, of course, left main coronary arteries, the right coronary artery, and vein grafts that have aortoosteal anastomotic sites. What is so special about left main? Dobrin this morning did mention certain histological characteristics of the left main ostium as well as the right coronary ostia. They're slightly different, but what is characteristic of both of these areas is that when you put something down there, there is significant degree of elastic recoil so that the ostium conforms slightly back to what it was, so that some of the gain that you get with balloon dilatation and putting stents in may be lost because of the presence of fibrosis and the way the muscles are arranged. Also, very often patients have a lot of aortic atherosclerosis with calcification that is right around the ostia, and so calcification of these territories also will cause a certain degree of recoil and lack of expansion of these areas. Now with vein grafts, they're of course put in the aorta, and there could be a lot of aortic disease that involves the ostium. More importantly, it is possible that the suture that the cardiac surgeon has placed to attach the vein graft to the aorta may cause some inflammation, and of course there could be that the suture is tightened so much that the aorto-ostial area is particularly narrow because of a mechanical property of the suture that's placed in that area. So when you have these kinds of diseases, aorto-ostial, what kind of stents do we need to use? Particularly, why is the left main a challenge? As you can see, this is an example of the ostium of the left main at the aorto-ostial junction, and one can imagine that any balloon or stent will be associated with a certain amount of elastic recoil. This is a stent that's placed at the ostium of the right coronary artery, and as you can see from the stent boost on the picture to the right, is that there is stent fracture. It is not unusual that the stent fractures of right coronary artery occur more often than it does in the left main coronary artery, very often because the stent hangs out of the right coronary artery, and because of the directions in which the aorta and the right coronary ostium move, there is weakness of that particular junction, and stent fracture can occur. And of course, this is a nidus then for stent restenosis. This is an example of vein graft ostial disease, and you can imagine that this could be very resistant to dilatation and stent placement. So what are the kind of stents that one can use in this area? Again, Dobrin presented the data from the Megatron stent from Boston Scientific, and as we have evolved in the stent era, we have now working with thinner stent struts. This Megatron stent is thicker than the 70-micron stents that are known with the ultra-thin stent struts, and this allows for greater radial strength and also allows for greater expansion of this particular stent. Because of the particular design of the Megatron stent, which was mentioned before, it has a higher range of expansion. So it can expand from 3.5 to 6 millimeters, which is not seen with any other stent. And as the left main sizes are different, and you have to match it to, say, the left anterior descending artery, which could be 4 millimeters, and the left main ostium could be 6 millimeters, you can use appropriate size balloons to match the diameter of the left main as well as the LAD, because it will expand to that range. Now, these thicker stent struts are not associated with any difference in terms of cumulative incidence of TLR and survival rates. As you can see in this graph, that the survival for all patients, complex and non-complex, is pretty much the same. So we have not lost anything in terms of the results if we use a thicker stent strut. So this is the description of the Synergy Megatron. You already heard it. And that figure in the circle shows that the stent can expand here, left main to 5 millimeters to 3.5 millimeters. You can do a part of the proximal segment without losing any integrity of the stent of the polymer that is there, nor will you have decrease in terms of the drug that's on it. So these are some of the clinical benefits of the Megatron stent, that it has it is stronger and it can expand quite nicely. So this stent can be used in the ostium of the left main, the body of the left main. If it gets down there, you can use it for the right coronary artery, and you can also use it for vein grafts. And it provides adequate amount of radial strength, hopefully reducing the degree of stent recoil and loss of the gain of the diameter. So this, again, this is a similar slide. I don't know if this was presented. Again, we have not lost anything in terms of TLR and adverse results by going backwards to using thicker stent struts. Obviously, these stents are harder to deliver, so one tends to use this in more proximal segments. Of course, if you can get it down the LAD, that's okay. So going from large vessels to small vessels, we know that when a diameter of the vessel is less than 2.5 millimeters, any stent size that is thick will automatically reduce the gain that you have by putting a stent in, because the thickness of the stent strut automatically reduces the gain by about 20% or so. So it is better to use ultra-thin stents for patients that have small vessels. Now, if vessel size of 2 millimeters, we generally tend not to stent. Why would you want to stent such small vessels? However, there are patients who have diffuse disease, such as patients with diabetes, small women, those patients that have renal failure, and more importantly, when you put a stent in the proximal segment of any vessel, if you have downstream disease, you are jeopardizing the proximal stent because the distal flow is reduced. So if you want to preserve the integrity of the proximal segment that you have stented, sometimes you are forced to stent small distal vessels, small distal branches, because you want to preserve the integrity of the proximal stent. So in those scenarios, so you have small vessels in a diabetic, small vessels that are diseased distal to the proximal stent, you may want to use these small stents. And again, here, the ultra-thin stents are very, very useful. And in the BioResort trials, what you see is that you haven't given up anything by using these stents. The older generation stent, like the nano stents from Xience in the SPIRIT trials, were not 2 millimeters, they were 2.5 and higher, and the TLR rates in those studies were a little higher. However, with the Biotronik ultra-thin stents, the results are very, very acceptable in small vessels. And this is the newest version of the Orsiro Mission DES stents. It is very deliverable because of the design of the stent, and also, as you heard this morning, the stent is embedded into the balloon so that it behaves just like a balloon. The disadvantage is that you cannot really see it well, so you have to have sharp eyes and high magnification. So we'll move on to the stents in diabetic patients. We know that diabetes per se is at a pro-inflammatory state, so that when you put a drug-eluting stent in a diabetic vessel, you're automatically increasing the degree of inflammation in the stent. So one would think that if you put a stent in that has biodegradable polymer, reducing the long-term inflammatory state, that this would be better. So is there any particular stent that is beneficial for such patients? Also, diabetics, again, as I mentioned, tend to have smaller diameter stents, so you may want to use ultra-thin stents. However, what has been seen is that in multiple trials, whether you use a thin strut stents or an ultra-thin stent strut, the results apparently are about the same. Whether you use a biodegradable polymer or whether you use a sustained a polymer that stays in place, a durable polymer, the results apparently are the same. So even though the theory is that if the polymer goes away, there's less inflammation, so it is better, it has not really been proven out in studies. What these graphs show very elegantly is that diabetics, no matter which stent you use, see they still have poorer results, that's up here, poorer results as compared to those patients that don't have diabetes. So by and large, all the lower graph lines are patients, non-diabetics, and so that the durable polymer as well as the biodegradable polymers behave the same way, in the sense that the outcome is the same, but what is ominous is that the diabetics do really poorly no matter what kind of stents that you use. So the long and short of it is that though we might think that one stent is better than the other stent in diabetics, they all tend to behave the same way, whether they have biodegradable polymer or not. Why am I having trouble with this? Okay. Then we have calcified lesions, and are there any particular stents that are better for calcified vessels? And the answer is not. So any stent can be used in calcified vessels with equally good short as well as long-term stents. The caveats are what I have put in red, and that is that the lesion preparation is very, very important. And then imaging, as we have mentioned, often pre and post will tell you what kind of lesion preparation you have to do. And more importantly, once the stent is placed, is the stent adequately opposed and expanded because of the resistant nature of the vessel? So imaging is more important than what kind of stent you use. Then we will move on to patients that are of high bleeding risks, and which stent. Should we use a stent that is biodegradable, has biodegradable polymers so that they heal faster and therefore you need less DAPT? Again, no matter which stent you look at, whether you look at the Synergy stent with the biodegradable abluminal polymer or the EES Xience stent with durable polymer, the overall results in short DAPT, whether it be 28 days, 90 days, or 6 months, is about the same no matter which stent you use. So don't let any industry guy tell you that one stent is better than the other in the high bleeding risks. And I will not go into details of this because this graph is hard to see, but basically what it shows is that the overall risks and the benefits are about the same no matter what stents you use, whether biodegradable or durable polymer. The outcome is the same in the high bleeding risk patients. For example, the Xience stent, the durable polymer, was used in the Xience 28 and 90, whereas the BioFlow trial used the biodegradable thin stent strut. So in summary, since my time is out, currently, in my opinion, any available stent that's on the market, the third generation stents, can be used interchangeably in most situations. However, there are certain characteristics of the stents that we have on the shelf, which is due to the stent thickness, the presence of absence of polymer, permanent or biodegradable polymer, that may dictate your judgment as to which stent you need to use in which case. The ultra thin stent struts do improve the outcome in vessel sizes that are 2 millimeters and below. So you would not want to put anything bigger in these thicker stent struts in these size vessels. The thicker stent struts, such as the Megatron, could be used and is indicated in left main lesions because of the size of the stent struts, which allows for greater radial strength and therefore less recoil, and plus the ability to expand in terms of sizes, so you can match both the proximal as well as the distal segment depending on the diameter size. In diabetics, biodegradable polymers do seem to make sense because, as I said, diabetes is a pro-inflammatory condition, and if you were to believe that the polymer itself is an inflammatory product, then you don't want to add more inflammation to diabetic patients. However, whether you use durable polymer or the biodegradable polymer, data after data suggests that they behave the same way in terms of TLR and long-term outcome, whether you're a diabetic or not. By and large, diabetics do poorly with stents as compared to non-diabetics. So risk modification in these patients are more important than what kind of stent you use. The second and the third generation stents are equally safe in those patients that have high bleeding risk. So the long and short is, by and large, you can use any stent you want in any situation. Preparation of the lesion is more important than the stent you use. Thank you for your attention. That's all I have to say.
Thank you, Professor Nair. Thank you, Ravi. Because our moderator has left, maybe to be involved into the cath lab, I will proceed. Okay, any questions and comments, Dr. Pavlovich?
Yes.
The short one, your personal opinion about selecting the stent in bifurcations. You didn't mention that subject.
I don't, for the distal left main, I think it is okay to use the Megatron stent, but there is no elastic recoil. But if you were to go part from 4 or 5 millimeters down to 2.5 millimeters, for example, I think it's okay to use a stent that has a wider range of diameter without compromising on this integrity of the stent. So instead of taking a 4 millimeter stent and going up to 6, you could use a Megatron. But I think all of these stents are now created that unless your experience is different, that the side entry is pretty good for most third generation, second and third generation stents. They're mostly all the same, including the Osiro thin strut. I don't think you give up anything.
So can we say that dedicated stents are not now so actual?
You mean
let's say?
bifurcation or any stent?
Yes, dedicated only for bifurcations.
No, I think there was a lot of excitement a few years ago, but rarely anybody is using it. I don't know why. I think they have not been developed to the point that it is easily used. I think these dedicated bifurcation stents, at least the one that I was aware of, have a larger platform. It is very hard to go down 6 French catheters. So when you're doing radial procedures all the time, it's very difficult.
They are bulky, yeah.
They're very bulky.
Yeah.
So
Okay.
done, right?
I like to hear your opinion because most drug-eluting stents from second generation on are now showing safety data about shorter DAPT.
DAPT, correct.
Still, do you think that it is preferable to have polymer-free or biodegradable polymer
See,
devices?
we haven't seen that, right? In BioFlow, we didn't see that. And in fact, the short DAP data, they used any kind of stent. It was done in Europe, any kind of stent, and they were all safe. But the thing is, it's DAPT. It's not no antiplatelets. In the 28 and 90 trial with Zymes, there were simple lesions. They didn't do it in bifurcation. They didn't do it in left main. They didn't do it in STEMI. And they omitted one of the agents. They didn't omit aspirin and Plavix. They omitted one. And in majority of cases, they omitted just aspirin. And even in the short DAP trial, it's not that both agents are stopped. It's one agent that is stopped. And I think in the short DAP trial, it was mostly aspirin that was stopped, but there were quite a few patients where Plavix was stopped. So it's not that you can stop both. It's that you stop one. It's not dual antiplatelet therapy, right? Yeah.
Can you describe for us in your imagination what's the perfect stent will be in the future?
I think these,
It's
I hate
not
to
easy,
say it, but I think the ultra-thin stent that has biodegradable polymer is probably the best kind of stent, because intuitively you don't like to leave the polymer behind, though they are behaving quite nicely, even though you have abluminal, even though you have polymer, like in the EES Zymes, it's a durable polymer. But if you can do away with it, who knows what happens in 5 and 10 years, right? So ultra-thin stent with biodegradable polymer seems like a good idea.
Okay, thank you. So we will move to the next lecture, role of imaging in DSS implantation. Professor Chico, it's your turn now.
Okay. Okay. So they have the control. That one. Okay. Okay, there should be sound here, but it's okay. You already heard Wagner, and you already saw Koblenz, which is my current location, which is probably the most beautiful bifurcation in Germany, You see the most beautiful Carina there. It is called the German corner. Okay, so let's talk today about imaging in DES implantation. I will beat Professor Michalis about provocative statements, but we will see afterwards. So, in 2002, we had the DES breakthrough. We were all enthusiastic about the results we saw. The restenosis rates were drastically reduced from 50% in the bare metal stent area, depending on the studies and on the patients, to 7.9, 8.9 of angiographic restenosis. And then we thought we weren't in front of a new horizon for PCI. We started to see we can do multivessel disease, left main, complex PCI, as we actually did. But these were statements we were doing and hearing at that time. Heart surgeons will soon operate only valves and endocarditis. The TAVI was not so developed at that time. But in 2006, after DSC in Barcelona, this Eduardo Camenzan was presenting these data that have been extensively addressed and showing that DS increased mortality and hard clinical endpoints. So we started to be discouraged and we had concerns about DES thrombosis. And actually, if you see the development of OCT, of optical coherence tomography, there is a huge rise after 2006. And it's because OCT was believed to bring us some light, to shed some light about what was the problem about this DS thrombosis. Why? Because mainly the companies were concerned about these device-related factors. Is there a device-related factor which we can improve or which is creating this problem? There were also clinical factors, non-compliance with the therapy, hematological factors, but there were several procedural factors. One of them was already unveiled or unraveled by IVUS. We knew from the bare metal stent era that underexpansion was a predictor of thrombosis and of restenosis. And pathology unraveled two additional factors, which were malapposition and delayed re-endothelialization. These two factors, malapposition and re-endothelialization, could potentially be assessed by OCT. And that's why there was a huge investment in developing the intracoronary OCT after this 2006 crisis. Which are the current indications for imaging in DES implantation? These are the European guidelines of 2014. I'm presenting them here because I think they were more clear than the current statement. And you can see that we have IVUS or OCT for stent optimization. IVUS has a 2A indication and OCT had at the time 2B indication. And both OCT and IVUS are indicated for stent failure. Stent failure understood as restenosis or thrombosis. And you can see the statements here with a 2A indication as well. In the update of the guidelines in 2018, the only thing that changes from this is that OCT is upgraded to 2A indication, but it is formulated on a more confused way. You see here that we have IVUS or OCT for optimization, 2A, both of them. But you see that for the stent failure, it's a bit more confused. You see for the stent thrombosis, it disappears from the tables, but you can read liberal use of intracoronary imaging in order to detect mechanical factors that could have provoked the thrombosis. And in the restenosis, we still are with a 2A indication in the guideline. So basically the same, but more confused. Let's see how we can use imaging for PCI optimization, the first of the indications that are approved by the guidelines. Let's start reviewing the evidence. IVUS, in all-comers populations, the use of IVUS improves stent thrombosis, definite and probable, myocardial infarction, and the combined endpoint of cardiac death and myocardial infarction and stent thrombosis, and revascularization. Significant in this sub-analysis of the ADAPT-DES. Take into account that the sample size is huge, 8,000 more than 8,000 patients, and more than 3,000 had IVUS. So this is the Framingham study of the IVUS use. And you see that there is significant evidence, overwhelming significant evidence. Important is an all-comers trial. There was no selection, that's just for the general population. Some shortcomings of this analysis is that in the IVUS group, more everolimus eluting stents were used than in the angiographic group, and this could have influenced the result. The use of IVUS was left up to the operator, and some operators never used IVUS, 0%, whilst other operators use it in 94% of the cases. So maybe we are seeing the effect not of the IVUS itself, but of the operators using IVUS, who are probably a different profile. The so-called operator bias. And there was no IVUS protocol. The study was observational. It didn't tell us you have to use IVUS before and measure this, that, or you have to use IVUS after the implantation and you have to assess this or that. So it was liberal use of IVUS during the intervention. And something which is puzzling is in the IVUS group there was also significant less bleeding. So this I can hardly explain why the use of IVUS in the coronary artery provokes less bleeding in the patient. However, if you think of it, it might make sense because IVUS is a long-term school. IVUS, if you have never used IVUS and you have a problem, don't expect that IVUS all of a sudden saves your ass and your patient's life. No, you need to use IVUS regularly and to learn after using it regularly, and then you start to become a better interventional cardiologist because it offers you a different perspective of your coronary artery, of your intervention, and of your complications. So probably the operators using IVUS were more academics or had a different perspective of how to treat their patients or how to offer them a solution. So this explanation might make sense. Apart of this, in different specific scenarios, like complex PCI interventions, like in the left main, you can see that the use of IVUS improves all-cause death. In the CTO, the use of IVUS improves the combined endpoint of cardiac death, myocardial infarction, revascularization, etc. And in summary, the more complex the scenario is, the larger the benefit of the use of imaging. Since we are in the Bulgarian bifurcation meeting, the next question is, what about bifurcations? Is it a complex enough scenario to have evidence about the use of imaging? And recently, in the last ESC meeting, we had the results of the October trial released, and here we proved for the first time that the use of OCT in bifurcations on a systematic way improves clinical outcomes. So this was a combined endpoint of cardiac death, target lesion-related MI, and target lesion revascularization at 2 years follow-up. Contrary to the ADAPT-DS, here there is a very strict OCT protocol. You have to do OCT before and assess some issues, some parameters, between the steps to check several things, and after the finishing the intervention and obtaining an optimal angiographic result. Key points for the success of the October trial is, for the first time, we are assessing bifurcation-specific parameters, like the wire recrossing, which cell are we crossing through, and the abluminal rewiring, which can be an issue in large bifurcations. And furthermore, I think, this is my personal impression, the bifurcation can be a more sensitive scenario for issues like sizing, apposition, and eventually also expansion, but definitely sizing and apposition. An issue that the October has to solve is why the difference starts at the point 0. So apparently the use of imaging also improves the pre-procedural complications, probably due to the definition of a pre-procedural MI. But you see that the curves start with advantage for OCT from the moment 0, but still keep on diverging over time. So this is an issue that probably deserves some clarification in the future, but does not annulate the study. What can we do to optimize the PCI? First of all, the imaging pre-PCI can be useful to define a clear strategy against calcium. Our strategy, let's be realistic, our strategy against calcium is most of times mechanically decided. I cannot go through, or the balloon cannot go through, and then you start to decide mechanically what you can use or what you cannot use. But now we have the intravascular lithotripsy, which I was very skeptical at the beginning, but now I am convinced. And with the imaging, you can see this typical imaging of napkin ring. If it is thick enough, there is no device that is going to help you more than the intravascular lithotripsy. So if you can obtain the imaging, your strategy against calcium gets simplified, utterly simplified. Keep in mind that you have an artificial intelligence-based software that can provide you a qualitative and quantitative analysis of the plaque in just one click. And the machine calculates and gives you the answer for you, as we published. Once we obtain the pullback pre-PCI, we said 1.5 years ago in RUSE, in the meeting in RUSE, something that was provocative, is that we should forget the Illumian criteria. The Illumian series is interesting for Sigmund Freud because it's a series of studies aimed to have a bigger area than IVUS or than angio, but that's not interesting for our patients. I'm sorry. Usually they are unrealistic goals, unrealistic targets, and it was clear that the studies, the Illumian 4, would be negative, as it was presented in the last ESC meeting. So I recommend to do more useful approach. First of all, keeping in mind something that I heard that people start to be aware. IVUS will always deliver bigger areas than OCT because of the physics underneath. So there is no surprise that if you decide to compare IVUS versus OCT, your OCT areas in 800 patients will be at the end significantly smaller. But this is not because of the effect of the OCT, it's because of the physics, of the frequency that the different systems are using. And very important, never go beyond the EEL. We always say that EEL is elastic, but not so elastic. So don't force things because you always have some plaque that to accommodate, and this is a way to have complications. So essentially, if you can measure the EEL, then you measure the diameter and you downsize the size of your stent, 0.5 millimeters, depending on the plaque burden you have to accommodate. In OCT, if you can only measure the lumen, then you upsize your stent accordingly. Keep in mind, if you are using this artificial intelligence software, the software based on OCT will deliver the internal elastic lamina, which is essentially very similar to the external elastic lamina. Also important, if you are using a sheath-based system like OCT, high-definition IVUS, you can precisely measure the length of the segment that you have to stent. Do not use imaging pre to decide whether you have to treat or not to treat the lesion. We were using that in the past, but it's not valid anymore. Only valid for IVUS in the left main, because of reasons that we have previously commented. But this is a strategy that is not possible anymore. Once we have implanted the stent and we obtain an angiographic result with OCT, we can assess the expansion and the system's color code if we have under expansion in red or we have right expansion, so they tell us what we have to optimize. And again, don't be too aggressive. There are some studies of optimization of results with higher mortality, just being too aggressive. And we can check malapposition. Remember, if we have 3 struts, embedded, protruding, and malapposed, with OCT, we will only see the adluminal border, the adluminal blooming. So we have to measure the distance to the vessel wall to assess whether we are malapposed or not. We need to know the strut thickness to do it properly. Here there is another misunderstanding. In the Illumian, it was 200 micrometers used as criterion, but actually in the paper that we used to quote it, we recommend 400 microns to assess a clinically meaningful distance, because below 400 microns is most of times, more than 90% of the times, spontaneously corrected and heals with no consequence. So, another issue that we can check are the dissections, especially the distal dissections to the stents, and check if they are large enough, consider to tackle them with overlapping an additional stent. We should not use OCT to make any clinical decision based on strat coverage. And this is something not everybody has clear. We have learned that the stent thrombosis is much more complex. It's not just the neointimal coverage that we can approximate with OCT. There is also this protein adsorption that can be albumin absorbed to the stent strat or a fibrin adsorbed to the stent strands. And this is something that we do not fully understand and makes us, and you can believe me because I spent 3 years in Rotterdam aiming to demonstrate this, and finally we gave up. The evidence was against that. Just to keep in mind, since we are in a dedicated meeting, after my PhD, I got a nice present, one of the first Palma Schatz stents. I like to make the most of this meeting to make an interesting remark about OCT. This is Yogi Berra. This is a nice baseball player that people in the United States like because he's sympathetic and so on, but makes funny quotes. And one of these funny quotes is, "It's difficult to make predictions, especially about the future." Ha ha, we laugh because it's a simple baseball player and so on. But we have the equivalent to Yogi Berra in cardiology. This is probably the most wrongly quoted paper in the history of cardiology, because they state at the end, in the conclusions, the most powerful histological predictor of stent thrombosis was endothelial coverage, which is a funny conclusion for a necropsic study. I wonder what a pathologist can predict about the future of their patients or corpses. It's too late to predict any clinical event. So, if you want to write a paper about OCT coverage, don't start in the introduction saying, endothelial coverage is the most powerful histological predictor of stent thrombosis, because this will irritate the reviewer. Okay, imaging in device failure. Just if you do imaging in restenosis in 3 out of 4 cases, you will find a reason, mechanical reason for that restenosis that you can optimize. So it is worth to spend some money just to make the problem. And in thrombosis is the same. We have seen already several cases. Depending when the thrombosis happens, probably we have one cause or the other as a likely mechanism. But especially in the very late thrombosis, it is important to know whether we are in a hypersensitivity reaction, also called vasotoxic reaction, as we have mentioned here in previous talks. Well, this is one example of stent thrombosis in acute. This is the slide I wanted to mention, because this vasotoxic reaction or hypersensitivity reaction is associated to rich eosinophils infiltrate and to late acquired malapposition. And this is a different, this is a different mechanism to this case of stent thrombosis as well, that we can see here. It's a case of neoatherosclerosis, as Professor Michalis has also nicely presented. And other possibility, this is another stent thrombosis, and we can see here something waving. I don't know if the quality is enough for you to appreciate that in the augmented figure. When we do the OCT, we see a thrombus attached to one of the stents. We can recognize a taxus liberté distally and a science stent there. And there is a thrombus attached to one of them. Let's see to which one. If we analyze the thrombus after aspiration, there are no eosinophils, are neutrophils. So there is no inflammatory reaction like in the one we discovered. And if we look carefully to the stents, the taxus liberté, which probably would be the most likely to blame, according to the evidence we know, was, it's okay, okay. And the science stent was jailing, it was implanted in the circumflex, was jailing the LAD, and it was crushed in the left main. So probably due to a poor implantation in the previous procedure. And this is the stent where this funny thrombus was attaching. Keep in mind that using 3D OCT, that now has disappeared from Abbott console, you could recognize the type of stent using a 4-steps protocol, using the 3D and the longitudinal view. And also, advanced applications just mention that whatever you have a problem, use imaging. It was Julius Caesar, before Christ, when he came back to Rome after the Gallic Wars, 7 years wars, he summarized this 7-year war by saying, Veni, vidi, vici, which means I came, I saw, I won. So for Julius Caesar, it was clear. If you want to win, you have to see. If you encounter a difficulty, encounter a complication that you do not understand, remind Julius Caesar. See what is happening, understand, and win. So, in conclusion, imaging in this DS implantation improves clinical outcomes. Now we have compelling evidence in all comers PCI, as ADAPT-DS showed us, but especially in complex scenarios, left main CTO bifurcations. If you use imaging regularly, this will change your perspective. It's a long-term school. You will become a better cardiologist by using that, especially in DS failure or when you have any complication. Thank you very much for your attention. I hope to see you in June in our meeting in Koblenz.
Thank you, Professor Chico, for your nice presentation. At least for me, it's clear that I like very much your idea that if you have even any imaging tool in your cath lab, you are thinking more about your patients, and you obtain better results because you are more careful for your patient, at least that.
Yeah.
It could be not of the imaging, but you are more careful, more clever maybe.
Yeah.
About that. Okay, so any comments? Any questions? Very nice. Okay, what's your preferred imaging tool in the cath lab? What do you use?
Yeah, well,
every day?
I am biased towards OCT.
Yeah.
I always say OCT is better, but there are two scenarios in which I do also a lot of IVUS. CTO, your life will be much better if you use IVUS, because you spare the use of contrast and you are not injecting proximally, antegrade the contrast. So actually I am the third biggest IVUS user in my country in the CTO registry. And also in, ostial lesions. Ostial lesions, now we are about to publish a paper, a consensus about how to do OCT in ostial lesions.
Yeah,
but your life will be much more complicated than with the IVUS, so it depends. And these ostial lesions most of times includes also the left main, because in the left main at the end, even though it's a distal lesion that you could nicely see with OCT, most of times your stent goes quite proximal, and it's still the trend that we cover or scaffold with the stent up to the ostium, and then at the end you have to image the ostium, and it is far easier with the IVUS. And now with the high definition IVUS, 60 megahertz. I apologize to ADSIST for the live case because I said it was 45. It was 60 megahertz, the same as Boston. You saw in the live case, you have an absolutely gorgeous quality of the imaging.
Okay, if there are no questions, thank you very much, and the session is closed.